Thank you everyone for being here. Today is session 4 out of 6 of our health equity series, and we're going to go ahead and just jump right in. You can earn professional development credits for participating in the live sessions. Kyle did post a link in the chat with the pre-test, so please feel free to take that prior to the session, and we'll send out an evaluation afterwards. We are offering CMEs, social work, and nursing credits for this series. And to receive credit, just please fill out that pre-test and post-test that'll be in the chat later on. And we'll go ahead and jump right into introductions. I'm Krista Opsdahl. I'm the Project ECHO Director here at the North Dakota Center for Persons with Disabilities. I'll pass it over to Jody.
Hi, I'm Jody Patchen. I'm the Project Assistant for the ECHO series. Kyle?
I'm Kyle Erickson. I am the evaluator for the ECHO series, and I'll also be the case presentator a little later on.
Thank you. And we want to give a shout out to our hub team. We've been working with Family Voices and the University of Wyoming and the North Dakota Department of Health and Human Services to bring you this series. So thank you all for your wonderful content and helping us with this series. And I'll go ahead and pass it over to our presenter, Dr. Q. So please welcome. I'll go ahead and stop sharing so you can take over.
Perfect. Are you guys able to see my slide? Wonderful. And I think closed captioning is on. I just have to move something for a second so I can actually see. Perfect. Okay. Well, thank you all very much for joining me over your lunch hour. Like I said, like Krista said, I am my full name is Nguyen Quang Thuy, which is a tonal language. It's Vietnamese. And so in English, it doesn't translate very well. A lot of people will say Quang Thuy Nguyen, which is probably about as best as you can get. And I share with folks that they should feel comfortable calling me Q or Dr. Q or Dr. Nguyen and not worrying too much, because if you are in the early childhood space, you understand that the way our brains process and learn, especially language, it significantly decreases after you turn 3 and definitely after you turn 8. And while the ability to acquire another language is something that can still be lifelong, the kind of fluency and the kind of brain wiring that you have to be able to get through is really hard. And so I tell people, hey, just go ahead and call me Q. Okay, so our objectives today are to kind of go over the healthcare challenges that we see by youth and adults with intellectual and developmental disability, describe some of the best practices and opportunities that we have, and talk a little bit more about preventative care measures and screenings that we can do a better job with. So I instead of a bio slide, I put in a positionality slide because I think it helps to have people really understand where I come from, not necessarily the academic merits that qualify me to be in this space. So I graduated from med school a while ago, and I actually worked as a general pediatrician 5 full days a week at Group Health North Shore, which is up in the Pacific Northwest. I trained in the Northeast, and it was my first time in the Northwest. And working full time, which was amazing and fantastic. In 2016, we moved to Utah, and I began staffing at the University of Utah Developmental Assessment Clinic, which was partly a travel clinic at the time. And so as you can imagine, it was really hard to get people to commit to these kinds of clinics. Once a month, we'd be flying into places like, the Blanding area of Utah, some really remote corners, taking like a 5-person, 6-person plane. Someone else was on the land, was doing the ground travel, and would show up with all these testing kits. After a few years of doing this work, we realized that what we were doing wasn't really helping enough with the community. We actually switched to a telehealth model, and I can talk a little bit more about that. And now I work as both a general pediatrician as well as a pediatrician who works in a developmental clinic. I say that because I actually never got boarded or certified in developmental and behavioral pediatrics. but I've been in a multidisciplinary development clinic for nearly 10 years now. And so there's a lot that I've learned from just being in the community. I'm an active member of the AAP. I'm on the Council for Children with Disabilities, the Council for Early Childhood, and the Section on Minority Health, Equity, and Inclusion. And I currently serve in the department as our Vice Chair for Justice, Equity, Diversity, Inclusion, which will be outlawed going July 1st onward because of the changes to Utah state law. But, you know, I came to this work not just from a minority background or as a refugee, but also because some of the training experiences and work experiences I've had with communities that may struggle with some of the disabilities we talk about. So I want to start first and say that pediatrics has changed. And I think those of you who are in this space can fully recognize and acknowledge that. There are estimates that about 20% of the childhood population struggle with some sort of special healthcare need. And it's hard when you're walking into your clinic day to figure out if it's going to be this child, or maybe this child, or maybe that child in the back. Sometimes the disabilities and the challenges are visible, and sometimes they're not visible until there is a stressful enough situation that you can see where this family or this child might be struggling. In addition to the change in the demographics, we also have lots of different variations in how families structure the care for their children, right? And so as frontline folks providing services for families, you kind of have to be prepared to handle just about anything these days. And I don't know if folks on the call might agree with that. And the American Academy of Pediatrics, like I said, has done a pretty good job of bringing some of these conversations to the front. This is the Bright Futures chapter on working with children and families. Really nice breakdown of some of the different roles that a clinic might try to utilize when they're examining workflow, thinking about pre-visit activities, during the visit, and then post-visit activities. When I look at a lot of these materials, I'm really impressed by all they do, but also, quite frankly, overwhelmed sometimes, because when you're staffing a lot of patients, being able to manage a complex algorithm can be very stressful and hard to do. And it's no wonder that despite how much we might say we need to work with and recognize communities that have disabilities, the trouble is that we don't. And the structures that we have put in place are not actually reflective of the things that we say we really want to do. Because if you look at the outcomes kind of speak for themselves. And I think it's just important to acknowledge that. There are some studies that will say, yes, the general pediatric clinic should be the medical home. But then there are other studies that'll show that people are really uncomfortable serving kids and families with special needs. And so there's definitely this disconnect between what we say we want to do or what we're prepared to do versus the actual service of it. And I don't think I would be, and I'm speaking from both the evidence base as well as from personal experiences working in Gen Peds clinic as well as in a development clinic. But at least we try. And in some spaces, we have an easier time than others. So like I said, this is another slide from Bright Futures. And I love how we center the child in the middle of this space, you know, with a medical home and a pediatrician and a care coordinator, but also the therapists and the school and the social workers, as well as the medical specialists. What we know is that as medical technology has progressed, a lot of the kids who may not have made it through early childhood are now surviving into adulthood. And over time, you might see the neurologist just once a year. You might not even see the cardiologist anymore. You may graduate from the GI clinic because now you don't have to be tube fed and you're able to sustain your own sustenance. So this really, how are we actually thinking about our relationship with their autonomy and their growth. See this mom, she's holding her umbrella over her child, and I can guarantee you, she herself is battling with the sun and the heat. And that's what we do. We're used to taking care of and providing for those that we love. It's sometimes safer and easier to do that. But as this person grows up, it's not necessarily better. And we have to challenge ourselves and say, hey, are we actually giving people a full chance to develop and grow the way that we may with children who may not have these same challenges? This is Erickson's model of human development. There's other models of human development like Piaget's model and stuff. But what I like about this is it at least gives you a sense of some values. And, the question, do we allow children and youth to progress and explore these different values, or do we impose them on them because we assume we might know for them? How do we even start these conversations? So we can't really talk about this without talking a little bit about bias. Bias is actually just a normal part of the way the brain works based on exposure and past experiences. I can walk up to a door and I know intuitively whether I'm supposed to push the door or pull the door based on the visual signals I see and the visual signals that have worked for me in the past. My own experiences, how I grew up, also affect what I project into the world. And as I've become a physician working with patients in this space, I've learned that no matter how smart I might be or how many degrees or where they are from, I do not really understand what living as a person who may have a disability is like. And that ableism is going to be one of the biases that I have to constantly deal with. So this is a personal experience and a personal story. When I was in medical school, there was a grant, one of the federal grants that funded a group of what we called ASL deaf scholars, and that's deaf with a capital D. These medical students were taught American Sign Language and were committed to weekly lectures and exposure opportunities in the community. So we did some health workshops in sign language and stuff like that. And we also got to spend a summer at Gallaudet, which some of you may know, institutions for those who are deaf and hard of hearing. So I spent my summer there. One of my first classes, the professor said, and it's a real loss and it's really sad when you have a deaf family who experiences the birth of a hearing child. And I was like, I don't understand that. Like, why would you be sad or upset about them being able to hear? And that professor was so kind. He didn't make me feel bad. He just very honestly said, when a child is born hearing, the dynamics between the parent and the child relationship really changes. They don't necessarily go to deaf schools. They don't have deaf friends. The immersion in deaf culture is different. And so as much as we may be very happy about the child, we're also very concerned about the loss that at the same time having to fight this fear of loss and inability to connect with their child. That was amazing for me in my own ableism lens to recognize at that moment and confront, and over the years, I've learned other things. I've had, patients who said to me, well, no, the teachers at the school are it's just not working for us and they're ignoring him. And I'm like, oh no, again, professional bias, the structural biases. The teachers are trained, they must know what they're doing. I'm sure that, we can do something to help Johnny a little bit more. And I still remember this woman, she's must have been from some part of the Southeast, always had her hair pulled back really tight. And she was a grandmother raising her grandson. Hair pulled back into this tight bun. She had like these curly bangs that would stick right out, and they were always really tough, really stiff. And she said, if the teacher's really good and you think that she is, then why is she placing her desk to face out the window and putting her back to the whole classroom? And again, that was a chance for me to think, oh my gosh, yeah, look at my own biases. I'm just assuming everything should be happening the way it's supposed to, without actually listening to this family explain exactly what they see and recognize how critical they are in being able to evaluate how things are working or not working for them. And so being able to kind of let the family have that voice and interrupt you when you are projecting something is again, very, very important. I suspect I probably am preaching a little bit to the choir given the community that's on this transition echo today, but I do want to just be very upfront and honest about how we all need to acknowledge that when we're working with our communities. This is some work that's been done by Sabrina Darrington. She is a bioethicist and she's also a pediatric critical care physician at UCLA. And what I love about this, so this is from one of her papers, what I really love is just the idea that whether it's following a critical illness or whether it's a child or an individual with disabilities, we're really surrounded by community. And you cannot isolate just the individual and expect that you'll be able to help them achieve health, because outside of your exam room, and sometimes even in your exam room, there's a whole family unit of people who work with and are around this person and love this person, and then networks in which they're working or going to school, and then the environment. How does the environment and the perception of the community affect this individual as they navigate their life? Ultimately, everything we do is going to be through the lens of the family, especially for those who may have intellectual or developmental disabilities. And you can't, in like some of the other models, just go straight to the patient. You have to be able to navigate some of these interrelationships between all the different folks who may be a part of their lives. So there are multiple key transitions in life. There's those that are going from toddler to elementary school, childhood to adolescence, middle school to high school, and then high school to adulthood. I try to talk to people about these interval transitions, but I also try to have conversations about how is the stuff that we're doing today in their toddler years or in their elementary school years helping them to anchor in their adult life. So when you're talking to folks about like social skills, for example, and you might be just working with a 6-year-old who's struggling with eye contact and the ability to verbalize and advocate for himself. I tell them, so when you go up to your boss as an adult and you say, I deserve a raise, is it more impactful if you're able to sit and look at them and tell them in a clear, concrete manner what you deserve? Or is it more impactful to kind of come into the room, be afraid to look up, be spending a lot of time trying to figure out what they're interpreting from your messaging? How are you able to really fully advocate for yourself as an adult if we don't practice these skills from the time that they are children into their adolescence and then into their young adulthood? So we spend a lot of time in my visits talking about this, and this is both in my development clinic as well as in my primary care clinic, which tends to have a lot more patients who have special needs. And this is really interesting data because what we know too is that adults who have intellectual and developmental disabilities can have significant challenges with their health. So this is a paper from 2015 looking at adult data. So this paper is almost 10 years old, looking at adults. My guess is in the future, we'll actually have more numbers of patients who are surviving childhood into adulthood and even doing well enough that they're in systems that we can count and look at their health metrics, right? But so, like I said, this paper is from 2015. And if you look at the developmental disability category, so what they did was they looked at there was a national data set. And the author was really frank and said, hey, it can sometimes be really hard to get data because the numbers that we have of patients with developmental disabilities can be really, really small. And so it can be hard to do a lot of extrapolation. But again, like I said, as our medical technology is improving, my suspicion is that the same way that we have changing fractions of patients who have special needs in the pediatric clinic, and it's at 20%, we'll also have changing demographics in the adult data about who is surviving into adulthood and also managing these disabilities as adults. So these numbers, look at this, they put people into 3 different groups and they looked at some of these health outcomes. And what they found was that when it came to smoking, those who had no disability had a prevalence rate of about 15%. Those who had some disability, and this could have included motor disability, mental health disability, they were at a higher percent. And those with developmental disabilities actually had a lower percent of smoking behaviors. What they found was that those with developmental disabilities had a lower likelihood of being overweight, but had a higher likelihood of being obese as compared to the no disability group. And this was an interesting parameter as well, which is looking at physical activity in the last month. So what they found is those with no disabilities were physically active. Those with some disabilities were active about 22% of the time. And those with developmental disabilities, about roughly half of the folks have been able to be active, but significantly higher in terms of lack of physical exercise or movement or activity than those with no disabilities. And this last category, I think, is especially important: emotional support. Those who have no disabilities described a percentage rate of about 7.2%. Those with developmental disabilities said about 32% of the population felt that there was lack of adequate emotional support. These are some additional factors to look at. And some interesting things. So those with developmental disabilities were more likely to have had a physical in the past year. So this rate was, no physical exam. So fewer, like the majority of them had been able to access healthcare and have physical exams. And yet things like PSAs and cancer screenings or pap smears were significantly less likely in that population, despite being in. And why is that? We don't talk a lot about sexuality for those who are young adults and youth when it comes to those with developmental disabilities. And what we know is that the AAP has defined sexual education as a sort of whole group of different content. So it can be about human sexuality, including relationships, anatomy, conversations about reproduction, conversations about STIs, orientation, identity, abstinence and contraception, and reproductive rights and responsibilities. This is a hard thing to talk about. Even with a neurotypical population, they find that we're doing it maybe less than half the time. On average, we spend about 40 seconds talking about this. So when we're working with populations with special needs, we're probably even more likely to shortchange our community when it comes to access to this information. And why is it important? So there are studies that have shown that those with special needs are going to be at a higher risk for adverse outcomes. So young women with intellectual disability were at the highest risk for a diagnosed sexually transmitted infection. And this was a study that was done looking at both middle school and high school students in Philadelphia. And what they found was across the board, those with intellectual and developmental disabilities had higher risk of STI as compared to the typical population, and that this particular population was most vulnerable. There have been some studies from Canada looking at fertility rates, and found that young women with intellectual disability were just as fertile as their unaffected peers. However, they tended to have poor health pregnancy outcomes, and that's data from Sweden, and so should be considered a high-risk group. As pediatricians, how often are we having these conversations with our patients and their families to help their families understand and contextualize why this is important? I clicked twice instead of once. The sexual abuse risk can be as much as 4.6 times higher And some of the factors could be increased vulnerability and dependence on relatives, lack of sorry, I think it's saying my internet connection is unstable, so hopefully it's still connecting okay. Lack of sexual health education to be able to teach or guide what is appropriate versus inappropriate touch with patients and their families. It's also hard to make it concrete sometimes. This is actually a really great paper from Walters. And some of the questions I really liked were things like, you know, are you, one of my favorite questions is question number 4. So who decides whether you use condoms or not? Or are you planning on having children? When? How do you meet your partners? Have you ever been touched? So these are, and just yesterday, I actually had a visit with a family, and she has an 11-year-old who has started to masturbate and touch himself. And we had a conversation about, you know, appropriateness and, you know, what is a natural human instinct. And how do you explain that, you know, some of this might be okay, but then you don't want to be doing it in public spaces, but in the privacy of your own room, that'd be okay. How much is too much? And then in some cases, like if you're having difficulties, what are some of the barriers you can both agree on? So like, for example, having pants with a belt, so it's harder to access some of these more sensitive areas, especially when you're out in public. This paper was full of very concrete, specific information that I really enjoyed. And I highly encourage you to think about going over the papers. And some parts of the papers are a little hard because, you know, there are some ethical challenges and thoughts that, again, like I said, we walk into these spaces with our own biases, and having them challenged can be interesting. But if there's challenge, and that means that there's opportunity for more reflection and more thoughtful, critical thinking to be able to navigate these spaces and feel about that, that I often will tell folks, then it's time for us to lean into it even further so that we can understand it better and navigate it in a way that is true to all of us. Mental health is also a big issue for those with intellectual and developmental disabilities. There are estimates that about 40% of the population may have some sort of difficulty. And it shows in long-term outcomes. Again, this is looking at adult data, but what they did was they looked at, so they looked at populations with just mental health challenges. And then they looked at populations with intellectual and developmental disability only. And then they looked at populations with both intellectual IDD and mental health and addiction problems. And as you can see, so for example, when you're looking at the hazard ratios or the likelihood of having to go into long-term care, what you see is for the mental health population, there's a risk of 37%. But when you look at the IDD and MHA community, you're looking at 81%. And like I said, some of the data has suggested that approximately up to 40% of folks with IDD may have some risk for a mental health disorder. This is a big part of the population, and addressing this is significant. When it comes to premature mortality rates, again, there's a 38% risk for those with mental health challenges alone. But if you're looking at IDD and mental health, closer to 74%. This is fairly recent data. This is actually from 2021. So I encourage people to start talking about mental health in your clinic visits and from an early age. In my own practice, I may start medication for kids as early as, you know, sometimes 3, more oftentimes maybe 4. It depends on the severity of some of the symptoms, being low and slow titration. Sometimes I don't adjust medications for 3 or 4 weeks at a time. But I always tell people that the medicine has to be worth you taking it. So I want to make sure this medicine is actually benefiting you. If you are hesitant or equivocal, then there's no reason to take the medicine. And I want you to be honest and transparent with me, because then we can do that decision together. please don't say that you think it's working if you don't think it's working, because it's not a problem for me. I'm here to help serve you. And so you need to be in a better place with these meds. Otherwise, don't do it, And so I'm very honest with them about it. I work with a lot of kids with autism spectrum, and I share with some of my families, while the ASD is bad sometimes for some of my kids, it's the ADHD or the anxiety that's actually crippling them. And being able to manage that better can help them function much better within their school settings, home settings, or public settings. And for some of my families that are really hesitant, and I can tell that they're really struggling, there are lots of, calls from the school, parents are having to come in and pick up their child. The child themselves may want to do things, but then they can't because of some of these mental health challenges. So I have some kids who are actually pretty social, but they really struggle with going to spaces with other people, but they want to be there. They just can't. And I remind folks that while we always have to think about the side effects of medication, we also have to think about the side effects of not treating too. So if you're getting 20 hours of ABA or 30 hours of ABA a week, but you have so much inattention and so much hyperactivity that you're not benefiting from those hours, sometimes trying a medication course to see if it can help means that then you're benefiting from those hours of therapy, those sessions of therapy that you're doing. And again, this is a situation where it's a child as well as the family and the care ultimately has to benefit the child.
Dr.
Obesity is
Pugh,
another health issue, and then obesity. And I think, as I had shared in one of those first slides, obesity is high blood pressure, cardiovascular disease. Yeah. Is my internet connection unstable again?
yeah, I was gonna say, do you want to try turning off your video just to see if that helps a little bit?
Oh yeah, that's a great idea. Thank you. Okay, perfect. Hopefully that makes it a little easier. So we've talked about sexual health, we've talked about mental health, and I want to make a point of touching on the risk of obesity too. So we know that obesity can lead to a fair number of other health issues that can be very hard to manage. One of the things I tell my families is, I'm honest with them. I say, hey, we're seeing a lot of my kids who may have IDD when they're younger, they tend to be underweight, but as they get older, there's a higher tendency for them to be overweight, and the data supports that. The data says that there's a 3 to 6 times risk of that of children who are typically developing. And I'm honest with them. I say, hey, so if we end up on the route where we develop diabetes, how prepared are you to be checking sugars and doing shots? How prepared is your child to handle those activities to manage their own medical health? And so this is a space where being able to do a lot of prevention can have a significant impact. But it's hard to do this because, in some cases there's lack of interest or motivation. Sometimes there's not a recreational space that is safe, or classes or acceptance or integration within the community. So if you're going to go to the gym has to be a safe space for you if you have intellectual and developmental disability. Otherwise, you can't go. You have to worry about when that child or that adult is out. Are they going to be, will they alone? Well, are they safe? A lot of my families end finding that it's easier for them to control things at home. So they stay really homebound and develop habits around the home. But then that can really limit the sort of experience of activity, of physical activity. And certain medications, like we talk about mental health, some medications can actually make you gain weight. And so you may be at an increased risk from your medication and your other treatment modalities. Never mind sort of the underlying rigidity you may have around like dietary changes, sensory needs, or behavior change. So oftentimes in my visits in elementary school, I will talk to families about, hey, you guys know that if we think about practicing something now, it'll be more likely that this is a behavior that, John will be able to continue as an adult. Even myself, it's hard for me to get outside and exercise on a regular basis. But I'd more likely to do that if that was something we did when I was a child. McPherson looked at some conversations around weight, and he looked at both families with kids with disabilities and families with kids who were healthy. And there were a lot of consistencies between the two. So they both said, hey, don't talk about weight and size. Talk about growth and health. That's a better way to talk about this. Make sure you're giving strengths-based and solution-focused conversations. And then for those with for caregivers of kids with autism spectrum disorder, they said, hey, a concrete approach is better. So people don't necessarily not want this communication. They do, but they want it in a way that they can use it and be concrete about it. So one of the things I'll do is I'll tell folks, I don't care what you look like, but I do care about what your plate looks like. So tell me what your plate looks like for dinner. Tell me what your plate looks like for lunch. And then we start talking about like rules. Well, you should always have something green on your plate. Again, being sort of more rule-based or more concrete with the recommendations and engaging the child or the adult in the choices that they make. And depending on capacity, giving them more and more autonomy to be able to figure out how to be involved in their own health. And so if you have a rule like, hey, we always take a walk after dinner, then that becomes a lifestyle habit that they're more likely to maintain. Hey, we always make sure that there's one vegetable, whether or not you eat it, let's put it on the plate because, you know, we follow this food plate or something. Again, being concrete, talking about health instead of weight and size and appearance. So considerations for improvement that I want to just take a quick look at the time. So listen completely when you're working with families and don't be afraid to talk about the future, set goals, be honest about health outcomes. People deserve to know what could be a part of their future and be engaged in preventive measures from early on about how to mitigate design versus end user feedback versus no feedback at all. And then consider technology and communication tools. So I often will ask folks, you know, I see families and I will say, so tell me, what does Sally dress herself? And they'll say, yeah, Sally can dress herself, but I still have to help her decide what to wear on whether that is weather appropriate or activity appropriate. You know, there are a lot of families where if you actually ask, it's you learn. No, they're still using pull-ups or they're still using a diaper at night. And so not being afraid and just saying, hey, I just want to know what your everyday life looks like. Tell me about your activities of daily living. These stories can give you a much better idea about how this person is functioning in their everyday life. And then don't be afraid to talk to them about how are they moving towards adulthood. Let them start telling you what their goals are. I have a kid with trisomy 21 and autism spectrum, and her when she was 8 or 9, you know, I talked to her a little bit about how some of the universities have programs that that can allow, you know, admission to college and whether that college experience would be valuable for her and whether that was something that they wanted to think about or because you'd want to start planning for that. And her mom was like, honestly, you know, I think if you talk to her, like from what I can see, I think she'd be very happy just working in a flower shop. I don't think she needs that college experience. She'd be very happy that in the flower shop, working with a couple of people that she knows with beautiful plants around her every day. And that the pace of you know, the quiet of that space. And I was like, hey, that's really cool. I am so glad I learned that. I couldn't have learned that if I had not started the conversation about what do you see your child doing or what do you think your child want to do as they approach adulthood. And as they get older, then being able to kind of incorporate more of the person's voice or that youth's voice in the framing of what would make them happy. I talk about co-design a little bit, because like I said, there are lots of things for me. They're able to offset the biases in our design and can make sure that the product that we're building is actually the product that they need. Because if I build a product that is useless, then why bother? But if I can build something that's actually helpful, then that's work that is really noteworthy and laudable. So one of my favorite organizations in Utah is the Utah Parent Center. All of the parents and consultants who work at the Utah Parent Center have children who have had to navigate through the school process and have had to get IEPs or 504s. The next couple of pages actually come from some of the transition materials that are available on the UPC website. So if you go to resources, and I think it's called Transition University, they have 3 different books. Some of them are workbooks that you can go through with the young adults. Some of them are materials that are specifically about guardianship and legal or financial factors that you need to be able to understand or think about. Some more expensive, some less expensive. So really great set of resources. What I love about this particular chart is it breaks things down into a number of different life categories. And then it has at the top a framework by which a caregiver or a therapist or a doctor can start talking and make sure that they're comprehensive and that they're not assuming things and working on their biases. Again, these tools can help you be able to elicit the feedback and the information you actually need to support someone. So they have 3 different categories here. I can decide with no extra support, I need support, and I need someone to decide for me. And the categories, for example, in community living is something that is, like I said, concrete, right? Do I decide where I live and who I live with? Do I make safe choices around my home? Turning off the stove, having fire alarms, locking doors? Do I decide about how I keep my home or room clean and livable? Do I make choices about places that I travel to? And again, I can decide with no support, I need support, or I need someone to decide for me. And this may change. You can start talking about some of this at age 8, and then again at age 12, and then at again age 16. Being honest about this also gives the young adult a chance to see, oh, these are some of the things I need to be able to do, work to be able to help guide families into that adulthood. And like all materials at the UPC, parents were involved in a lot of the co-design because this reflects parents. This does not reflect doctors at all. The life trajectory worksheet is another great example, again, visual, and kind of showing how things are interrelated and then can have different outcomes so that you can work through these and be able to help to support decision-making for the young adult. And this is one of my last slides. So at the top here, they have personal strengths and assets. So that's the person. On the side in purple here, they have relationships for supporting daily life. At the bottom, they have in the light green eligibility supports. So that might be things like special education or a disability case manager or a coordinator. And then over here in the blue, the dark blue, there's community resources. And then in the red, there's technology for supporting daily life. So being able to diagram all the different resources that can be a part of an individual and part of their support team and tools also makes it easier for groups of caregivers to be able to help support the individual. And it's not just one person who holds all this information. And so transitions, like, you know, in some cases, maybe there's an uncle who goes to a visit with a person. And then next week, it may be a brother who's going to a visit with a young adult. Then this makes it a lot easier to really understand and be able to be coordinated and work with each other. Digital platforms also have a lot of promise. So I encourage all my families to use them. And sometimes I, as a PCP, I don't always get the specialty notes. And so I'll literally sit with them and I'll be like, hey, can you pull up the cardiology note? Because now they have on these EMRs, they have access to their notes. And so I'll read the note with them in the visit and go, oh, okay, so they don't need to see your health records can be really complicated. So having access to their imaging and the results of the medication is very, very helpful. Telehealth visits. So like I said, we switched from an in-person model where we traveled and flew to once a year to our clinics, and the visits outside of that can be through telehealth, and people have been really happy with it. There have been telehealth Zooms with me where we would talk about how they were doing, and we didn't have to cancel the appointment. There have been times where I've had visits from like a school class, like a school conference room, and the teacher is able to join in the conversation with me and the family as well, because the family had access and could do it remotely. I've had families parked in the school, do their visit with me, and then send John into school like only 10 minutes late, and not take out 2 or 3 hours of their day to come and see me. And so there's a lot of benefits to telehealth. And what we've actually seen is that, so this is a paper that looked at feasibility, and a review article that looked at feasibility of synchronous or telehealth visits. And what they found was that you didn't have any worse outcomes. So outcomes were actually similar, about the same, but you had a lot of increase in patient satisfaction. I do both in-person visits and telehealth visits, and had a family who've been following with me for a while. They said, hey, can we see you in person? And I was like, of course. I'm at the Lehigh Hospital on Fridays. And so they came and saw me in person. And at the end of the visit, they're like, can we go back to the Zoom visits? And I said, yes. And so you don't know until you ask. But I do think when you have restrictions on how much sick time you have, or like there are differences in where people are living or who's participating in the care, Zoom actually allows for a lot of access that doesn't otherwise, that may otherwise be minimized. This is actually a really exciting paper. What they're doing is they're looking at 500 patients with intellectual disability and mental health challenges and conditions. And what they're doing is they're doing a 1-to-1 stratification, looking at in-person consultation versus telehealth, and they're examining outcomes. So they were just describing the paper. I'm excited results in a few years, looking at diversion from emergency services and quality of care, or perceived quality of care, as well as mental health ability. And I'll try to wrap up in 2 more minutes. And then the last thing I wanted to say is, don't forget that being visual or using a number of different modalities can really help with increasing your communication. So visual supports can be very helpful. Today I wanted to have the captioning on because, like I said, it can support those who may have trouble more with oral processing, those who may use languages other than English, those who just need something written out to be able to remember. And so use simple language, don't speak louder, and consider these supports. This is a reference from, this was published with the Robert Wood Johnson. This is funded by the Robert Wood Johnson Foundation, and these are universal symbols that we can use in healthcare. So this may be a valuable resource, but think a little bit about, are our clinics just with written language? Do we use pictures in some of the diagrams? When we're talking to patients, are we using social stories to kind of explain how they're getting their vitals, and then they're going to an exam room, and then they're going to see the doctor, and then they're going to go home? And it can all be pretty daunting, but it can also be a lot of fun. And so every journey, no matter how big or small, starts with just a single step. And sometimes that is just even asking. I took a little longer than I meant to. I'm sorry.
No, that was wonderful. Thank you so much. If you guys have any questions, please feel free to put them in the chat, and then we can address them after the case presentation. I do want to comment, I absolutely love that you talked about the My Plate and how to approach that. I can't tell you how many people I've worked with. I come from the disability service field, and how much trauma has happened because doctors have told the people that I was working with that they were overweight and that they had to, go on these diets and just the amount of behaviors and stuff. And it always bothered me like how it was framed. It was always about their weight and size, but I love that I want to see what your plate looks like because I'm concerned about your health. Like that is such a kind and concrete way of putting that. So thank you for sharing that. I wasn't expecting that from this, but that's a huge takeaway for me.
Yeah, and being really specific, like you need to have one green thing on your plate. And sometimes if you can develop a good habit in someone who has rigid behaviors, that's great. So like talk to the families about that and say like, hey, if you develop a habit where you always walk after dinner, that's great. Keep going with that.
Exactly. And Amy put in the chat, images in healthcare super interesting on your last slides and the use of social stories. So we'll make sure that we include some additional resources on, I know that there's tons of websites out there for easy social story making. So we'll definitely include that because I think that that's a wonderful resource as well. All right, well, we are going to go ahead and introduce our case presenter for today, Mr. Kyle Erickson.
Hello. So I was invited to give the case presentation about a little bit about my experience with it. So yeah, let's get into it. When I was about 9 months old, I was diagnosed with cerebral palsy, specifically the spastic quadriplegic kind. So it means all my muscles are constantly retracted in, and I do use a wheelchair. And specifically to kind of relate to this session, I want to talk about kind of how my transition from childhood to adulthood came in and kind of the pitfalls of it. So I actually I had my pediatrician as my primary physician all through college because I couldn't find a physician that was comfortable with all my healthcare needs. And even with my pediatrician, he would basically tell me what you need, let's get it done. And but he wasn't able to like provide any information or advice on his end. So up until it was only because I'm 30, I just turned 35 or 34 a few months ago, and I just like a year and a half ago got myself set up with a physical rehabilitation doctor because in the rural community that we live in, those kind of specialists are hard to come by. And before I got set up with this specialist, it was more the same, tell me what you need and I'll write your script for it, which was great, but it required a lot of research on my end. And there's that phrase, you don't know what you don't know. So I feel like a lot of my healthcare needs were kind of neglected up until a couple of years ago. What's nice about the physician I have now is that rather than me tell him, hey, this is what I need, he's actually making suggestions to me about my future. Because like I'm a very now concentrated person, and we are starting to have more conversations about what my disability is gonna look like, when I'm 40, 50, 60, which is really nice because it's prepared me for the future. Yeah, so now I'm gonna open it up to any questions. Basically, we kind of want to provide somebody from the other side of the healthcare transition equation to give some feedback and just a little share some of my experiences, so hopefully they can help you guys out. Are there any questions?
Feel free to unmute or put any questions in the chat. One thing that really sticks out to me about your story, Kyle, is all of like the research that we've done and a lot of the presentations we've sat through with this series, they talk about, empowering the person with the disability to like advocate at the doctor's office, to like tell doctors like what you need. And it's so interesting how that kind of was almost a pitfall for you.
Yeah, exactly. It was a people because I didn't know what I didn't know, and I thought I had a pretty good handle on it until I got in a room with a healthcare professional with some expertise with my diagnosis. And there's a whole laundry list of stuff that I never even thought about that I'm trying to wrap my head around right now.
So there's a balance is kind
Yeah,
of what you're saying.
it's all about balance.
Like listening to the patients and like trusting that they are the expert, but also still providing care.
Yeah, absolutely, absolutely. And let's see. And so did anybody else have any other questions?
How did you find your position? I mean, what were some of the questions you asked to find the position that
I
helped you?
am an expert Googler. So I just was Googling for a physical rehab doctor once a few years ago, and his name just popped up. So I just called and I booked myself an appointment.
Very cool. Thank you. So you basically see a physical rehab doctor as your primary
Yeah,
physician?
exactly. I see him more than I do my GP these days.
Okay.
And Kyle, you wanted some feedback from the participants, right?
Yeah, I had a few questions. So if the group like I wanted to get some kind of expert advice on a few questions I had. So, but first I want to check one more time. Is there any other questions from the group? Okay, fantastic. So I was wondering if you guys could help me brainstorm some solutions for some questions I have. So for the first thing I was wondering, what questions can I ask my healthcare provider to make sure that I like age well and I like maintain my independence? Because my ability to live independently is very important to me. So it's just that's my main concern right now. Does anybody have any ideas?
This is Q. I turned off my video feed and hopefully my audio is working okay. I think being able to kind of address some of those things that I talked about, like physical activity, understanding healthy choices, recognizing the role of community and social health to long-term outcomes as well. And not being afraid to say like, this is a challenge for me. What are the things that we can use in our community to make sure we mitigate or offset some of this? But I think it has to be, you shouldn't be shy about any of these topics. And honestly, like even in a neurotypical population, some of these topics are a little taboo. That doesn't mean that they don't deserve recognition and appreciation and attention in your medical visits with your doctor. And so like I would definitely make sure they're addressing all those categories, your sexual health, your mental health, as well as your, from the most part, most of us are pretty, after you've made it into the adulthood, like I said, the cardiology visits go down a little bit and they're only once a year. The GI visits might be once a year, depends on the condition.
Fantastic. I just want to point out that I'm getting some really good feedback in the chat too. Some suggestions have been just ask how you can age safely in your home with supports. Ask how I can be connected with mentors who have done it well. And ask your doctor about preventive care. The preventative care is something that I have a really hard time with because of my personality. I don't take very good care of myself just in general. So preventative care is kind of a foreign concept to me. So I'm gonna have to get better about that. Another question I had, and I wanted to see if you guys had the answers to. So, up until recently, my only concern had to be was living independently with my diagnosis. Recently, my plate has gotten a little bit full. I work full time. I I do comedy on the side. What can I do to ensure that I can maintain my diagnosis while keeping this new active lifestyle that I've kind of adopted recently? Because that's been a concern of mine too. Did the question make sense to people?
It's funny, actually, now that I'm trying to like wrap my mind around how we framed that question.
Yeah, because it was really interesting. Because before I had like all I had to do was concentrate on just being able to live in my house and do things independently. And now, while trying to maintain all these other stuff, I'm concerned that keeping track of my diagnosis is gonna fall to the wayside. Make sure you stay in touch with your doctor and you're staying healthy. Okay. Diagram also where you at, where you want to go. That's a really good idea.
I think also, knowing what your family history is and knowing how your family has aged. So you
Yeah.
can recognize things that you might have tendencies towards. Like, I mean, use for example, my family, there's like 4 or 5 generations of diabetes on both sides of my family. So knowing that, type 2 diabetes mainly, so knowing that you can do things that you can adapt to prepare yourself so that you might be diagnosed, but also so that you can delay diagnosis.
Okay, that's a really good idea.
And things, and also with hypertension and things like that, so you can help, so you can be proactive in dealing with some of those things. So try to get as good of a family history from your parents and other relatives. And if your parents aren't willing to give you a good history, go to your aunts, your uncles, or your grandparents and get that from them.
Oh, my parents love talking about themselves almost as much as I do, so that shouldn't be a problem.
That's perfect. Have a great family have a great family time this weekend talking about illness.
Exactly, sounds like a good Easter.
Exactly.
Yeah, actually, the timing of this case presentation was perfect. You got Easter coming up.
Right, we can talk about family illness.
Well, these are great suggestions, and I see that we've gone over 5 minutes. So thank you guys, everyone, for hanging on, and thank you, Kyle, for sharing your story. And
Yeah, and thank you, because like I was willing for this was as much of a learning thing for me as kind of sharing my experiences. So I appreciate the group.
I actually want to use Dr. Q's suggestions about diagramming where you're at, where you want to go, and what you're at risk of slipping into, because that's very relevant to me and my
Yeah.
mental health. So, yeah, me and Kyle are gonna do that together, I think, after
Right.
this. And I think you might have missed one comment. There's one that says take the time for self-care, which I think is really great and important.
Oh yeah. Yeah, absolutely. Yeah.
Yeah.
Oh, so yeah, I just want to thank everybody for helping me out. And yeah, Chris, did you have anything? Oh, I almost forgot the post test.
Yeah, so
I will drop that into the chat.
perfect. So yeah, Kyle is going to put the post test in there, and we hope that we see you at our next session, which is next Wednesday. That'll be session 5 of 6. And thank you so much, Dr. Q, for sharing your expertise today. I know that you were in the middle of planning some big event, or I can't remember what exactly it was, but that was such a thorough presentation. So thank you so much for taking the time out to do that and share your passion for serving this group.
It's really my pleasure. It's really, really my pleasure, and thank you for letting me be here with you guys today and taking part of your day.
Yes, thank you.